Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, May 29, 2025, we are speaking to Dr. Judith Currier, a professor of medicine at UCLA. Dr. Currier is Executive Vice Chair for Research and co-director of the UCLA Charles Drew University Center for AIDS Research and the Sue and Michael Steinberg Chair in Global AIDS Research in the Department of Medicine at UCLA. Dr. Currier has over 25 years of experience in the design, implementation, conduct, and analysis of clinical trials to optimize antiretroviral treatment and management of HIV infection, as well as related complications of HIV. Today, Dr. Currier joins us to talk about next-gen HIV treatments, the latest in antiretroviral therapy advances. Judy, welcome to the podcast.
Thank you, Mike. It's great to be here with you today.
Well, it's wonderful to have you. We've been wanting to have a review of new drugs, but before we start, why do we need them? Why do we need any new drugs?
Yeah, a great question. I mean, we do really have a lot of options. I think 35 different drugs and 6 broad classes that are available, and many single tablet, formulations. And I think for a lot of people, what we have is working really well. But we still do have people who are not able to achieve viral suppression. And so we need new drugs or new ways of delivering them. And I think so that's really the main driver of new drugs today, of how we can better control HIV.
It seems like we've gone through a couple of eras, if you will, of antiviral treatment. We had the early drugs, which were mostly nucleosides and non-nucleoside agents, went on to protease inhibitors and then integrase inhibitors. So we had almost tapped out on approaching the virus from a mechanistic standpoint, where we target a life cycle event of the virus and its replication and attack that. The latest lenacapavir, which we're going to talk about a bit, is a capsid inhibitor. We may go into that, but it seems like most of our focus now is on the pharmacokinetic profile of the drugs so that we get longer acting drugs. What's your opinion about the need for that? You just touched on it a little bit, but where is that going to come into play?
Yeah, I mean, I think just before getting into that, though, it's worth taking a second just to pause to just, reflect on the incredible investments in biomedical research that have made the drug development in HIV possible. And it's happening at this moment in time when there's active dismantling of so much biomedical research and so much is at stake. And here's HIV, one of the HIV therapeutics, one of the biggest developments of the last half century. So, and it's been really based on what we know about the virus and what we learned about the life cycle of the virus and its vulnerabilities. And it's also had real benefits to other fields. So, that sort of public service announcement aside, I think it's important to reflect on how important this research has been for our country and for the world. But getting to lenacapavir and the capsid target, which is a new target, and I think one that is a good target because it supposedly doesn't mutate a lot. And the longer acting, the whole point here is that for people who struggle to take a tablet daily, who have either issues in their life that make it difficult, or psychologically. I've had, patients who just the daily reminder of taking a pill it has caused a lot of trauma. And so being able to take something less frequently really frees the person from thinking about their HIV all the time. And lenacapavir is an exciting compound because it can be given every 6 months. Which is, for prevention, it's really a major breakthrough. But for treatment, it's initially shown to be effective in highly treatment experienced patients when given along with other agents. So I think that it's going to fill a gap, potentially, if it can find some other partners to come along on the twice yearly dosing journey to really provide a freeing experience for people to be able to take their medications less frequently.
Yeah, thank you first off for that PSA. We'll maybe come back to that at the end because we really should celebrate the investment in science that got us to where we are today. Because both of us were involved in the earlier days of HIV where we didn't have that many options, and now the options are amazing. But to your point, it's always struck me that I can have some folks in their 50s who I'm treating, and they could be on 6 other medications, but they still ask, "Can I get on a long-acting HIV medication regimen? Because I don't like taking that pill even once a day, and they're taking 5 other medications, and they want to just not have to deal with the HIV in their face every day."
Yeah, I think when the first long-acting combination of cabotegravir and rilpivirine came along, which now is a every 2 monthly dosed regimen, I think there was a little bit of a disconnect between people living with HIV and their providers, and that providers really didn't think that people would want to come in every 2 months to get an injection when they can come and see their provider maybe once or twice a year to be monitored on their daily pills. But study after study have shown that participants' quality of life really has improved when they switch to the longer acting combination. Now, that's every 2 months right now. There is a formulation of cabotegravir more concentrated that might be able to be given every 4 months. That's being studied, and a prodrug that's being investigated that could be given less frequently as every 6 to 12 months. But they need partners, these drugs, to be given less frequently. And I actually just had a patient yesterday who wasn't interested in every 2 months. And it was sort of going back and forth with them about, well, what about every 6 months? No. Well, what about once a year? Yes. If you can get once a year, I'm in. That will be for that person, that was the threshold. And I think it's very different. People have different priorities here, and it's good to have options that will meet people where they are.
It, it's it's incredible to have options, and we can tailor treatment to where the patient is, and that's the ideal. And uh, I think the other area that we haven't mentioned yet is those individuals who, for whatever reason, have trouble keeping up with even a single pill once a day, and they end up struggling with getting their virus under control and using some of these longer acting drugs, in particular the cabotegravir, rilpivirine, um, even when they have detectable viremia, has been a game changer for those individuals because they'll come in for their visits initially once a month and then stretch it out to every 2 months, but they just have trouble taking that single tablet regimen. Have you had patients like that in your practice?
Not, personally, I haven't, but certainly there are a lot of reports in the literature of, I think that one of the issues that people are really investigating right now is whether the currently available 6 month formulation of lenacapavir can be combined with cabotegravir given every 2 months, sort of at every 2 months you get one, and then every other time you get the 6 month dose. So while they're not exactly the same, they can be lined up to be similar. And there are some for people who have really no other options and have had trouble with adherence. There's some really promising preliminary data that suggests that this might be an option. And so I think we're going to see more data coming out about that as an option. The thing we got to remember, though, about that is not for people with hepatitis B, because all of our other 3 drug regimens usually have 2 active drugs against Hep B. So we got to remember to vaccinate people against hepatitis B, and also that the safety of these it's not going to work if they have underlying Hep B. So we have to be monitoring for that.
I'm glad you brought that up. Um, so we're looking for these longer acting drugs. You mentioned lenacapavir now could be in combination with cabotegravir without the rilpivirine. So those two together in the regimen schedule that you just mentioned. What are some other things that you see on the horizon that could be used longer acting, and even if it's more than just once a day, once a week, once a month? What are you seeing?
Yeah, I mean, I think the other thing that's being investigated is doravirine and islatravir. So doravirine, a non-nucleoside reverse transcriptase inhibitor, and islatravir, a non-nucleoside transcription translocation inhibitor. So it does both. So islatravir, started out the gate at a higher dose, 0.75 milligrams, and initially in people with HIV, they saw trends of declining CD4 count, which was completely unexpected. So they had to go back to the drawing board and then restudy it at lower doses. And the 0.25 milligram dose was studied with on a daily basis with the islatravir. And that looked really comparable in people who were stable on their treatment that switched to a daily regimen of doravirine and islatravir was non-inferior to continuing on their treatment. And most of these new drugs are first studied in people who are stable on their treatment. So that's a really key point. So that, established that activity. Now islatravir can also be given once a week. So once weekly islatravir and once weekly lenacapavir, oral lenacapavir, are also now being studied. And whether a once weekly option is going to be a game changer for people that don't want a daily option, I think it really is one of these things yet to be seen. And some of the research really looking at, patient preferences. There may be people that would be, that would be a real advance for to take something once a week rather than getting a shot, because it is a pill. I think people would prefer a pill over a shot. Whether once a week is infrequent enough to really make a difference for people who struggle with adherence, more to be seen. So that is one thing that's out there.
Let's dig in just a brief moment to talk about that CD4 count decline with the 0.75. My understanding of it is that it wasn't targeting specifically CD4 counts, but rather dropped the total lymphocyte count altogether so that CD4% stayed more or less the same, but the absolute count of lymphocytes dropped. Therefore, because it's just a simple calculation, the CD4 counts were noticed to go down. Is that accurate?
I think that's right. Yeah, and it was around 30 was the magnitude. I think in that first study that people started out with CD4 counts pretty high, 680 or something, above 600, and that was the decline. I have not really kept up with the mechanism by which that happens, but I think they've really been very careful in assessing this in the lower doses, and they've not seen that decline. So that's important. And then, I think the lenacapavir, so that I think it's hard to keep track of drugs when they come in. The same drug comes in different formulations and different intervals, but oral once a week, sub-Q every 6 months. And now, they're investigating it once a year, lenacapavir. Whether that will be viable for treatment or only for prevention is yet to be seen. But again, it's got to find a partner that can come along on that ride, because a single agent isn't going to be enough.
I think it's really important to sort that out too, because for prevention, one drug is probably sufficient. In the once a year could be again more of a game changer than even the every 6 months, where lenacapavir is about to be approved. We're at the end of May 2025. We're expecting this to be approved by the FDA in the next month or two for prevention, and that will help every 6 months. But going to once a year, that's even better. But like you said, when we're talking about treatment as opposed to prevention, we got to pair it up with something else. Otherwise, we're just giving monotherapy, and that's been shown over time to put the patient at risk for developing resistant virus. Um, Other drugs that you're seeing, you mentioned islatravir, doravirine, um, lenacapavir, cabotegravir. Any other sort of things bubbling up in the horizon that you think might be potential treatments?
Yeah, I think there's interest in these broadly neutralizing antibodies as a therapeutic, and so these are there are long-acting broadly neutralizing antibodies that can be given every 6 months. So far, they're given by infusion, but I think technology is there that someday we would get to where they could be given sub-Q. But so this is there's studies with lenacapavir and two broadly neutralizing antibodies that have names that are always hard to remember how to pronounce. But they are there has been a study, phase 2 study, in people that were suppressed, either switching to this infusion of the two antibodies with the sub-Q lenacapavir every 6 months, or staying on their standard therapy, and they maintained virologic suppression, at good rates, over 95%. These broadly neutralizing antibodies, like other drugs, you can develop resistance to them, and sometimes there's pre-existing resistance. You think about the immune system is in people with HIV is making antibodies against a virus all the time to try to sort of fight back, and the response, the virus keeps evolving, and the antibodies don't win. So, but combining two together that somebody's susceptible for, and that can be tested for before the treatment is given, could be a viable approach. I think it is. It's a heavy bar because it's you now you've got to do susceptibility testing. You have to figure out, can you make a sub-Q version of it? But if it's a fully 6-month regimen, that really could be something. So there's a lot of work going on to look at broadly neutralizing antibodies as a possible component, both for prevention as well as for treatment.
Yeah. I was smiling as you were going through that because when I started in the field in the mid 80s, my first in lab experiment was looking at evolution of the virus in response to the immune system. In other words, the antibody would be produced to the virus, and then it's like cat and mouse. The virus would then change, and then a new antibody would be produced by the body, and it was just the virus is always 2 to 3 steps ahead. But you mentioned the term broadly neutralizing, which means it's not exactly even like COVID antibodies, which we used to use, bamlanivimab and others, that worked incredibly well, but that virus doesn't change as rapidly as HIV does. So we need the broadly neutralizing antibodies.
Right. That's right. The COVID virus doesn't change as fast, but it did change. So they had a limited lifespan. Those antibodies. So yes, indeed. And the ones that I was talking about, terapavimab and zivlerimab, I can never pronounce them, are the ones that were combined with lenacapavir. But they really are making their way through development, and I think there's something that people will continue to hear about.
Yeah, and if we can get it to, they change the FC portion of the antibody, that sort of stem, and maybe they can make it even longer acting. So there's ways to do that. So again, recapping, we've got the capsid inhibitor lenacapavir, cabotegravir integrase, islatravir, the translocation inhibitor doravirine, and non-nuc. We're sort of taking advantage of all these targets within the viral life cycle, and then broadly neutralizing antibodies that affect the ability of the virus to bind and enter the cell. All of this is exciting. One of the other things that maybe we can touch on briefly is different ways of delivering. So you mentioned infusion, you mentioned injection, we got pills, of course, but they're talking about making patches that could be long acting. So you could theoretically put a patch on somebody, assuming it stays on, and give continuous drug delivery. And the other idea is potentially even an implant where we could do like we do with progesterone derivatives for um, fertility or birth control, where you could put an implant in that could last up to 6 months, maybe longer. What are your thoughts on those modalities?
Yeah, no, I think it's really exciting, and you look at sort of also the progress that's been made in delivery of treatment for diabetes, and ways of monitoring people as well. I think we can see, maybe see evolution in that, and ways to make it easier to monitor people without needing to come into the clinic even, or giving blood samples the way we do. So I'm excited about the potential future opportunities for new methods of delivery. I think also we shouldn't forget to mention the relatively newer drugs that are available for highly treatment experienced patients, ibalizumab and fostemsavir. Most of us don't ever use those drugs, but it's important to know that they're there for people who have a lot of treatment experience and resistance. Generally, they're not going to be resistant to those or lenacapavir, and so now it is possible to construct for some people with a lot of prior treatment and resistance a regimen that might control their virus. So that is, I think, in places that don't see a lot of HIV or treatment experienced HIV, just being aware that those things are available and getting help from somebody who has experience in using them is something that we didn't have to offer just even a few years ago.
Correct. And ibalizumab is a monoclonal antibody formulation, and fostemsavir is also pretty effective. It's given twice a day, if I'm not mistaken. But when you're running out of options, having that available option is a nice perk that we can tap into. So I want to pull back to where you started. Just looking at the big picture, 40 years of antiretroviral therapeutics at this point. AZT was discovered in the 80s, and then we've come to this point where we have an incredible number of people who are having enormous success. I just yesterday I saw a patient who was in his late 70s making his 13th trip to Italy. This time to go to the Amalfi Coast. He's healthy, he's enjoying life, and diagnosed in the late 80s, early 90s. And here he is, really, really functional and doing well. And I think that's a tribute to the science. And you mentioned that the celebration of the science is something we shouldn't overlook. I think all of us are concerned about where it's heading right now. So you're in the middle of this. You're a leader of the AIDS Clinical Trials Group. What are you seeing happening in Washington, and what are your current concerns?
Yeah, I'm very worried about what's going on right now and how much of the progress that we've made is going to be eroded by actions. And I'm not sure, um, I don't understand why the intentions would be what they've turned out to be here in terms of dismantling both biomedical research enterprise, canceling grants, really destroying and not renewing, at least not yet, PEPFAR, which has made possible the expansion of these life-saving treatments globally. It's very, very concerning. Everyone should be concerned because this affects all of us. It affects the progress that we've made, economic stability, not to mention the moral and ethical obligations and the human toll that we'll see without the support globally. And I'm worried about the dismantling of programs in the U.S. as well. Cuts to HIV prevention and potential threats to Ryan White and Medicaid are going to make all of the progress that we've made towards trying to end the HIV epidemic. We have the tools that we need to do this, and we just need the political will, and we need to be really working to support people living with HIV and to support the HIV treatment response, not to try to unravel it. I'm very concerned about what's happening right now.
And what's remarkable is that historically, over the entire course, really from the late 80s onward, support for HIV research, the support for treatment programs like Ryan White have been truly bipartisan. I mean, these bills pass Congress, the funding bills, with 80, 75, 80, 90% of votes in the Senate and even in the House. And how this has changed in just the last 3 or 4 months is pretty striking. And as you mentioned, maybe it's worth us spending a moment just talking about the spinoffs. I mean, I remember saying even in college that the space race of the '60s gave us everything from Tang to Wang. In terms of ways to go into space and drink orange juice, but also the ability to get computer science up that we would have never had such an accelerated way. And the same thing's true for HIV. A lot of the work we did on virology in the 80s, 90s applied to hepatitis C to develop a cure that's 98% effective. I think the public maybe doesn't fully appreciate that, but when we start messing around and dismantling the infrastructures that have been active, there's a long-term consequence that I don't think is being considered strongly enough.
Yeah, there really have been so many off-target effects of the HIV investments in HIV research that are incredibly beneficial. You mentioned development of Hep C protease inhibitors, the mRNA work on CAR T cells that started in HIV that's really taken off and been transformational in cancer therapies. The list goes on, and it is really it just doesn't it's just not clear who's benefiting from some of the things that are happening. I'm all for being more efficient and having, trying to do things more efficiently, but to really dismantle investments that have been made in projects midstream is not efficient at all. It's very wasteful, and I think it's really really shameful what's happening right now.
Yeah. And one other thing we didn't mention is COVID. The whole Operation Warp Speed, that in an earlier podcast that we did with Tony Fauci, he described how not only Barney Graham coming up to him once the sequence was known in early January of 2020 of the COVID, SARS-CoV-2 virus, that they could design this vaccine and then take it through from phase 1, 2, 3 in less than 10 months.
Yeah.
And that was using existing trials networks, including many that were the HIV trials networks, the ACTG, the Prevention Network, the Vaccine Network, all around the world, and enrolled tens of thousands of people into randomized control studies in an impeccable way, working closely with the FDA and the pharmaceutical industry with the government to make this happen. And we should add that all happened during the first Trump administration. And
Right.
why
Yeah,
that's
that was the Trump program. Absolutely. And it really did show the value of the investments that have been made, the working together across all of these platforms and, all these parts of government with the private, public-private partnership to deliver results in a very timely manner, both for vaccines as well as for some of the early monoclonals and even some of the work that laid the groundwork for the approval of Paxlovid. So it is these investments do pay off, and I think really careful scrutiny as to what the actions that are being taken now are having on this. Is really important to do. So it is, we're at this kind of moment with HIV therapy where a lot of progress has been made, but there's a lot at stake right now, and I just can't emphasize enough how important it is for people to realize that the effects of these policies to reduce and diminish and stop things midstream is really wasteful.
very detrimental.
Yeah.
Judy, thank you for being with us today, and we'll keep our fingers crossed that the science can continue to move forward. Obviously, some bumps in the road, but I think you've outlined very nicely for us not only how far we've come, but what we have to look for in the future. And it is bright, assuming that we're able to do the work, and hopefully that will continue.
Yes. Thank you, Mike, so much. It's appreciate the opportunity to speak with you today.
Thanks. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.